Well, thanks, Julian, and thanks for the opportunity to speak here today. My relevant disclosure is I'm a consultant medical director for Monteris Medical, one of the LITT companies. So LITT is not new. It dates back to the 1990s, efforts in Germany and Boston to use fiber optic probes to heat the brain and to treat brain tumors. There were limitations at that time, however. First off, there was a lack of cooling, which led to char around the catheter, or fiber optic catheter, which limited the penetration of the heat. Also, there was no way to direct the laser probe. These were all full fires. And that there was no way to predict or monitor what was being ablated at the time. In theory, this was a good approach. Heat kills cells. And when you get to 43 degrees Celsius for long enough, you lead to apoptosis and necrosis. Above 57 degrees, you get coagulation, and then above that, you start to get some undesirable effects such as vaporization and carbonization. It's not just temperature, though. It's the relationship between temperature and time. This is the Arrhenius equation. And fortunately, computers are very good at doing this kind of thing in real time. All you need is the temperature, and MR thermography then came to the rescue, being very accurate in terms of changes in body temperature with respect to this technique. So if you plug all those numbers, the time and the temperature, into that equation, you can produce these predicted lines of thermal damage, so-called thermal damage threshold lines. In this case, the yellow line represents heating a tissue to 43 degrees Celsius for 2 minutes, the blue for 10 minutes, and then the white for an hour. It turns out anything outside the yellow line will recover. Anything inside the blue line will die. And anything inside the white line will also die, but by a different mechanism. So in practice, we use the yellow and blue lines. So using neuronavigation, we direct the laser probe into the tumor. This is the side-firing device. And we continue to ablate. Every 4 seconds, we get an update on those TDT lines, and we ablate out to the edge, and then stop ablating, rotate the probe using a robotic manipulator. We're in the MRI control room doing all this. And it's an iterative approach. We do a 5 millimeter layer, and once that's all done to our satisfaction, we then either advance or retract the probe. Now, this animation shows from going deep to superficial. I've changed to always going superficial to deep because we've had some cases of seeding along the biopsy, the laser track, and I'll show you a case of that a little bit later. But we've had no cases of seeding going from superficial to deep. This is what the thermal damage threshold lines look like. This is in an animal, and you'll see on the right side that this green field will start to turn red, and then rapidly you'll start to see the yellow and white lines develop as you're seeing right now. Again, this is from a side-firing probe. So there are 3 FDA-cleared systems out there. I've been using the one on the left, what was once known as the AutoLIT and now the NeuroBlade system. Medtronic has the Visualaze, and there's the ClearPoint Prism system as well. 2 of these are cooled systems. They all operate in the near-infrared. And you can see some of the other factors there that differentiate them. But they're all effective in doing laser ablations. Our first foray into this was the first in human study. This was in recurrent glioblastoma, not the topic of this talk. But this was a thermal dose escalation trial where patients who had difficult to operate or inoperable recurrent GBMs were subjected to laser ablation. The first 3 patients treated to the yellow line. If there were no adverse events or only one adverse event in 14 days, then they went on to the blue line, and similarly, they could then go on to the white line for the next 3. And this was done over an 11-month period starting in 2008 by the Cleveland Clinic and our friends down the street at the University Hospital's Cleveland Medical Center. 11 patients were enrolled and 10 were treated. All patients had treatment necrosis. We discovered that the lesions were between the blue and white TDT lines. As I alluded to, we use the blue line now for the treatments. The median survival was a pretty extended, selected group, but all 10 eventually died to disease progression. We looked at toxicities up to 14 days before moving on to the next cohort. And there were 2 steroid reversible neurologic deficits, one with a dysphagia and one with a visual field cut. One patient had an immediate hemiplegia at the other center. We used DTI routinely in our planning, but they did not. And in retrospect, they knocked off the corticospinal tract in that patient. One patient developed neutropenia, and 2 others developed DVTs during that period. There were 2 complications after 14 days. One had a delayed hemorrhage due to a pseudoaneurysm on a distal MCA branch, which may have been due to the biopsy or the laser ablation itself. Anyhow, they recovered very nicely. And then one had seeding along the biopsy therapy tract, as I alluded to earlier. This is what it looks like before and after in this corpus callosum recurrent GBM. The orange line represents the predicted TTT line kill, and you can see that in the 24-hour post-scan that the area that was coagulated very nicely matches what was predicted. If I had to do this again, I would come in on a trajectory that was along the long axis of this. By the limitations of the hardware we had at the time, I had to come down from above, but I think we could have gotten a complete ablation with the technologies we have today. This is the Kaplan-Meier curve again, a very select population, and this was published several years ago by our group and the group down the street at University Hospitals Cleveland Medical Center. So what did we learn from the FIH trial, first in humans trial, that LITT in human brain tumors is feasible? The TDT lines are indeed predictive of ablation. Extent of ablation is best observed at 24 to 48 hours with a T1 contrast MRI scan. Some neurological toxicities are reversible with edema, with steroids. Ablation stops at heat sinks such as ventricles, sulci, and large vessels. Fiber tracking is important, and this led to FDA clearance of this device. These days, this is the planning software that we use, and we can import fiber tracking objects, in this case from BrainLab, into our planning system so we can see exactly where these critical fibers are. In this case, we took the yellow TDT line right up to the corticospinal tract with no deficit. Now, radiation necrosis is one form of radiation injury. The types of radiation injury are defined by the how focal they are and also the timing of it during or after the radiation treatment. Acute injuries are indeed during or immediately after treatment, and they're typically reversible even if you don't treat them. Early delayed injuries such as pseudoprogression usually occurs in the first few months after radiation treatment, and again, it's usually reversible with or without treatment, and it's characterized by appearance on MRI that looks like a progressive tumor. Late injuries are called radiation necrosis, and the diffuse pattern is typically seen after whole brain radiation. This is irreversible. And the focal pattern is what we typically see after stereotactic radiosurgery. And this is an irreversible without treatment in most cases. The exact incidence of cerebral radiation necrosis is unknown, but in this paper in 2015, it was proposed to be as high as 35% at 24 months, which seems a little excessive from my experience. But we know from rat experiments that the necrosis is related to duration of exposure and cumulative dose, and that VEGF is a player in the mechanism that causes this. More about that in a moment. Nanaguchi looked at this in 11 samples of human radiation necrosis and found that there was little or no VEGF or anti-HIF-1 alpha in the area of actual necrosis, but this was abundant in the peri-necrosis area, which is where the vasculopathy occurs. And since VEGF is a known angiogenic peptide and also increases vascular permeability, this is probably a big player, as I alluded to, in the cause of and self-propagation of radiation necrosis. It does explain why some anticoagulants work, and also we'll talk about bevacizumab in a moment, but bevacizumab is an anti-VEGF agent. Inflammation may also play a part of this, but the key take-home point here is that radiation necrosis is a self-propagating vasculopathy or vasculitis with central necrosis. Since it is often associated with significant edema, steroids are a mainstay of treatment. Since it's blamed on vascular treatment, as I mentioned, anticoagulation, or in this case, Trental and vitamin E, have been used successfully. In the past, before bevacizumab, Open surgery for resection of radiation necrosis was sometimes used for refractory cases. Uncommonly, hyperbaric oxygen is used and may have a 70% success rate for a rather protracted treatment for these patients. The landmark paper, of course, was from Levin et al. Back in 2011, where 14 patients were treated with a placebo-controlled prospective randomized trial. And all the patients, either who were treated up front or on crossover, responded to bevacizumab, and none of those responded to placebo. So a landmark paper that's really changed how we approach this. We looked at our data back in 2013, and 23 out of the 24 patients responded nicely, and only one patient had a grade 3 adverse event. Now, to my knowledge, we were the first to report LITT as a successful treatment for focal radiation necrosis after stereotactic radiosurgery. And I would point out that this was actually the third publication we submitted this to, because in the first two, the reviewers could not wrap their head around trading radiation necrosis for coagulation necrosis. So this is our patient, a 75-year-old man who was treated with LINAC radiosurgery in Florida a year earlier. He was diabetic and had steroid-dependent radiation necrosis. You can see its relationship there to the corticospinal tract. And this is April of 2011 when he's on 16 milligrams of dexamethasone a day. He was treated with LITT, and this is his scan 1 month later without and with contrast on 0 milligrams of dexamethasone a day. You can see a substantial reduction in the size of that lesion and the enhancement of that lesion. Here we are at 3 months. Here we are at 6 months. Even more impressive is the T2 flare. On the left, 16 milligrams of dexamethasone a day. 1 month later, on 0 milligrams of dexamethasone a day. And he had a complete recovery of his neurologic function. Also, being steroid dependent and being diabetic, he actually had 3 toes amputated during that year from being on the steroids that long. We looked at a prospective trial that was multi-center, 6 patients, the laser trial, laser ablation after stereotactic radiosurgery. And in short, this was for failed radiosurgery and both recurrent tumor and radiation necrosis. 42 patients were analyzed. In terms of the patients who have tumor, it was the usual players for stereotactic radiosurgery. It was about a 75% response rate in this group, and that the KPS was unchanged or improved in 60% of the patients. 30% of the patients were able to stop or reduce steroid use. One of the take-home points here is that if you had a complete ablation of radiation necrosis, you had no recurrence at 12 weeks. If you had a complete ablation of tumor, 25% of the patients still recurred at 12 weeks. And there was a very small rehospitalization rate. So the take-home points was that laser ablation was a safe and effective treatment for failed radiosurgery. In the subsequent years, there have been a number of papers, a few reviews. I'll come back to those in a moment. Luther reported on 20 patients with biopsy-proven radiation necrosis treated with LITT with excellent results. A retrospective comparison of BEV versus a laser ablation showed a laser ablation survival benefit in 21. The time to steroid independence was better with laser ablation compared to BEV in 22. Another review, yet another review, radiographic results were the same in both groups, and the symptom improvement was better with BEV in the one paper. And then the ISRS had a review and recommendations. And what was common to all the reviews was that BEV and LITT are both effective, and the evidence is stronger for BEV. So briefly touching on evidence, I think we're all familiar with these. Prospective randomized controlled trials have really changed medicine. And what was common to all these things is that if something was highly effective or universally effective, you didn't need very many patients. On the other hand, if it wasn't highly effective or universally effective, you needed a lot of patients in order to prove this. And it's logistically and financially unfeasible to subject every question in medicine to these randomized controlled trials. In this particular paper from Chan, they showed that the effectiveness of the laser ablation for biopsy-proved radiation necrosis is in radiographically recurrent brain metastases. They concluded that radiation necrosis was not only, again, found to be safe with low patient morbidity, but also a highly effective treatment for radiation necrosis for both local control and symptom management. And this was from a prospective registry. I think the characteristics of LITT for radiation necrosis don't really lend itself to small prospective randomized trials. So this paper, I think, is notorious for looking at the randomized controlled studies that show that you can prevent death and injury from jumping out of an airplane with a parachute. And basically, they found that there was no evidence of a randomized controlled trial that would do that. And that there was a trial that actually was accomplished with 92 passengers who agreed to do this, and they did not find a parachute that did not significantly reduce death or major injury, but you have to look at the methods. They just jumped out of this biplane that was on the ground. So obvious, RCTs versus obvious. One critic of this is that the use and meaning of the parachute metaphor in biomedicine, and the results of that was that authors citing the parachute analogy are often critical of RCTs and often draw comparisons to interventions that are not parachutes, which is exactly what I'm doing. So in summary, LITT is a safe and effective treatment for SRS-induced radiation necrosis, particularly for deep or difficult to access lesions. Complete ablation of radiation necrosis leads to durable control. LITT leads to earlier steroid independence and better survival than medical management of post-SRS radiation necrosis. Some reports say superior survival with LITT versus bevacizumab, or at least equivalent, but there is the opportunity for stronger evidence, or I would submit, is it really necessary? These are my collaborators. On behalf of our team at the Rosella Burkhart Brain Tumor and Neuro-Oncology Center at the Cleveland Clinic, I thank you for your attention.
Thanks, Gene. And thanks for leading the way with LITT over the years. Such a spectacularly effective way of getting to target. Just wondering if you would provide some thoughts with the decoagulation and the inflammatory response that you generate with radiation necrosis. You're dealing with it, right? Which works really well. And we're seeing more radiation necrosis and immune modulation than we've ever seen, particularly with METs. How do you think it's going to turn out for our, when we actually treat it with LITT? We're going to induce an initial thermal event. The immune system is going to come and clean up as it does. How do you feel it's going to look like in 12, 18 months, kind of the latency period that we see post-radiation necrosis, particularly in heightened immune systems with ongoing immune therapy in these cases?
So you're asking about after LITT or after radiation necrosis?
So I wonder if, radiation necrosis is a form of thermal energy as well. So we see the effects 12 to 18 months later. Mm-hmm. With LITT, you're taking away the event. It's still a thermal event. What's it going to look like 12 to 18 months? And how do you feel it's going to be different from thermal energy as opposed to radiation?
Yeah, so you're dealing with ionizing radiation versus heat. And I think that they're two very different things. And the ionizing radiation does lead, again, to endothelial changes. It leads to astrocytes producing VEGF. There's no evidence that thermal ablation does that. And basically, once it's dead, it's dead. And there really there's no effect on the surrounding brain. I mean, that paper was published more than 10 years ago. And so we have a very long follow-up on these, and we're not seeing any adverse effects in the long-term survivors of LITT.
Yeah, that's an interesting finding. No, thank you.